last week I had this patient who was a 78-year-old lady who had a 2-week-old transcervical fracture with a dorsal femur. Now, if I take an opinion of the house here, I'm sure it will be a divided house as to which stem who's going to use. And what I've noticed is most of the time the choice of the stem depends on the training that one has got during residency, the experiences that one has had during whatever practice or of orthopedics they've had, and the most important thing is the confidence in your anesthesia and the ICU team, if you want. So what are the choices we have? Now, we have the age-old cemented, where the cement helps us in fixation. It can be used in poor quality bone. You can get the implant in the perfect position, restore the offset and limb lengths, and get a perfect anatomy. Revision is also not easy, and the most important thing, it is cost effective. Very important in our country here. The disadvantage is longer operative time, and the most scariest part is this thromboembolism or the BCIs that happens. On the other side, we have an uncemented stem. It relies on good bone quality. So you need to have a DOR A or a DOR B kind of like a femur, and it depends on osseointegration. Yes, there is lesser operative time, perceived to be lesser intraoperative complications, but most of the literature shows that there is a high risk of periprosthetic fracture. If you don't use a good quality implant and don't do it properly, you can have subsidence and you can have a residual thigh pain, and which can really have its own issues. So in a case of arthroplasty, we have unique issues. Patient is old, they have a higher ASA, or they are high risk patients, and they have very poor quality bone, and many of them have immobilized for longer time, so there is a risk of venous thromboembolism. Most of us, or most of the people who don't do cemented hips, do it for this is the major reason, where they are scared of the bone cement implantation syndrome. Some of them don't have confidence in their cementing technique, think that their cement mantle may not be good, or some of them feel that the survivorship is an issue. But most of that survivorship, or most of the failed cemented hips that we see were mainly because of polywear or poly issues, which has been now solved. So if you go through registry data, most of the data will show that the cemented stems do as well, if not better than an uncemented stem when it comes to survivorship. Americans have pushed into us to do uncemented stems, but if you look at this paper which analyzes the data from American Joint Replacement Registry, it also promotes cemented hip so as to avoid the high risk of periprosthetic fractures. So does cemented hip really have a higher mortality, which is perceived by a lot of people? So this is a study that we did at KEM. In 1 year, we studied all the hip procedures that we did, replacements, the bipolars as well as the THRs. We studied them perioperative with serological, clinical as well as radiological parameters. We studied intensely for 48 hours and then continued to follow up with them for a year. And this is what we found, that the stem did not really matter, and the most significant factors that led to mortality were whether it was a traumatic, like if it was following a fracture, it was a higher mortality. If the ASA grade was more than 2 in our setup, it was higher mortality. Post-op, we found that a lot of people had a higher TROP-T, meaning it was a cardiac event more than a thromboembolism. Yes, some of them had D-dimer. Our mortality was almost 5% in first 48 hours, but it had nothing to do with the implant. And at the end of 1 year, because they were fracture neck femurs, the mortality is almost 19%. So this type of stem really did not matter in our study, and this has been published now. There's another study where it is basically meta-analysis of 12 studies, where they have studied 1,805 patients, and they've seen that there is longer operative time with cemented arthroplasties, but they do as well as an uncemented. This is another study of 9 studies they were all RCTs, and again they found no difference. So this was another good article which says why are the use of cemented hips going down in multiple places? Purely because the training is not there. So most of the places or most of the hospitals which train number of residents have given up or are not really focusing on cemented hips. Yes, there is a longer operative time there, but the industry has pushed us, and the newer novel uncemented stems have made it more trendier to use uncemented stems, and a lot of people keep on using that instead of the cemented hips. So this is a good article. The term BCIS was coined in 2009 by the British anesthetists, and this is a good paper in 2014 which looked at 1,056 cemented hip procedures for fracture neck femur, and they found that grade 1 BCIS was seen in about 21%. There was a mortality which was associated, which was slightly higher, but most of them were because they were of grade 2 or grade 3 BCIS, and the predicting factors that they found was ASA grade 3 or 4, patients who had pulmonary hypertension, COPD, or were on warfarin or diuretics. So what is BCIS? We need to understand this, study it, so that the fear of cemented hip or cemented stems goes away. The mortality in this is about 0.4 to 1% if you see all the studies. It can happen in any cemented procedures. Initially it was thought monomer was the cause, but now we know that it is now a multimodal model, and the patient's response will depend on what is his physiological reserves, and that will decide what the response is going to be like. So it has been, the grading has been by Donaldson. So grade 1 is where the PO2 falls to about 94 and the BP does not go below 20%. Grade 2 is when the PO2 falls below 88 and the BP falls by 40%. And grade 3 is about a proper cardiovascular collapse which needs resuscitation. So to avoid this, most important thing is to anticipate, detect it early and manage it aggressively. So what are the risk factors? Risk factor is mainly patients. On the patient side, the patient has pre-existing pulmonary disease or pulmonary hypertension, any significant cardiac disease, old age and osteoporosis obviously contributes. If they are grade 3 or 4, yes. If the patients who are on diuretics or warfarin are at higher risk of getting this. On the surgical side, if it is a fracture or if it is an intertrochanteric fracture, there is a higher chance, pathological fracture, and if you use a longer stem, obviously there is a higher chance of BCIS. So most important thing is to recognize these risk factors, discuss it with your team. It will be a team approach which will help you get over it. So there are multiple times where it can happen, but mainly happens while femoral cementing and reduction. So best is a slow spinal anesthesia with low sedation. GA should be avoided. Make your own protocol with your team. Discuss it with the anesthetists. They need to be alert. Most of the changes that happen has to be treated by drugs, vasopressin, ionotropes rather than fluid overload. On the surgeon side, we need to have good hemostasis, give a good lavage and clean your canal, make it dry, plug it, vent it, use a low viscosity cement, vacuum mix definitely helps, avoid excessive pressurization in some of the cases, be gentle with your introduction of processes, use shorter stems. Avoid this position for a long time because it causes stasis and causes higher embolism. BCIS happens in the first 10 or 20 minutes, so observe your patient for 10 or 20 minutes, resuscitate it if required, maybe shift to ICU if it is required. So if you anticipate, detect early and manage as a team approach, you can really get over it. So I feel we should not give up on cemented stems because the quality of bone will decide what stem you are going to use, and as a society, I think it's our job to educate the upcoming surgeon as to how to use cemented stem safely so that they don't just give it up. Thank you.